Yeah. So thank you for inviting me to give this talk. I work right now at the WHO for the Cervical Cancer Elimination Initiative under the Department of Non-Communicable Diseases. I'm also a member of the International Agency for Research on Cancer in the branch of early detection, prevention, and infections. But now I'm at WHO for about another year, supporting the work towards the global elimination of cervical cancer. So, yeah, maybe this one. This one. Okay. Right. So I actually welcome the words of my previous speakers because the introduction was really well towards what we have with cervical cancer. Cervical cancer is a disease that actually presents us with a lot of global inequalities, as you could see in this map. According to GloboCan, which is the main robust data from cervical cancer, from cancer registries that is provided by IARC, in 2020, we had about 600,000 new cases of invasive cervical cancer and about 342,000 deaths due to this cancer, with about 90% of those happening in low and middle income countries. Cervical cancer remains to be the fourth most common cancer worldwide in women. And as you could see here, and as explained before, the largest incidence that we could see comes from sub-Saharan Africa, where also the HIV prevalence is the highest in the world. We could see, though, although here the rates don't show it that much, but we have countries like Eswatini with cervical cancer incidence of about 80 per 100,000 women, compared to countries like France, as shown before, that are about 10 per 100,000 or low. So the difference between, let's say, even the two hemispheres of the world are really striking. And this is why cervical cancer has always been thought about the cancer of the poor. So talking about women living with HIV, they are at least 6 times higher at risk of developing cervical cancer through life. Women and girls living with HIV have a higher risk of getting HPV infection, higher risk of having a persistent infection. They actually have lower chance of getting rid of the infection by themselves, faster progression from infection to cancer, lower regression of precancerous lesions, high recurrence after treatment, and usually, or sometimes, cervical cancer can present at younger ages. So in the hand right, we could see the map of the population attributable fraction of women with cervical cancer living with HIV. And again, we see this spot of sub-Saharan Africa, of course, where HIV prevalence is extremely high. I want to say that there are several issues regarding women living with HIV, particularly that there have not been enough studies showing us enough evidence on what we can do in terms of different evidence-based interventions that I'm going to talk about in a minute. So in 2018, the Director General of the World Health Organization, of WHO, called into action worldwide to actually eliminate cervical cancer as a public health problem. This was based on the fact that we all know that one woman dies of cervical cancer every 2 other minutes. And we know that cervical cancer is a fully preventable disease. So in 2013, Mark Schiffman and Nico Vensensen published this graph under a manuscript that has been throughout very well referred, which actually shows us the natural history model of cervical cancer, which starts with an HPV infection that may get into persistent and then can also regress. And if it does not regress, it can progress into a cervical lesion, a precancerous cervical lesion, that if it is not treated, will end up in a cancer. Most importantly, it was shown that there is a life course throughout the life of women where we can have different prevention measures to stop a woman from having cervical cancer. We know that the average peak age of HPV infection is about 20 years of age or a bit earlier, because it happens usually after sexual activity initiation. And then we have the peak of the pre-cancerous lesions around 30 to 40 years of age, and the cancer starting at about 45. In each of these steps, we have opportunities to actually stop progression into cancer. This is why we consider that cervical cancer is a fully preventable disease, and I will explain that in a minute. And actually, what actually has made the rate so high in many countries is because there has not been access to any of the tools that we have now. For years, we have had cytology available worldwide in the 1950s, but this has not been offered, at least not in an organized way or in a complete way to many women around the world. So the proposed elimination as a public health problem, and I want to highlight that, actually consider a threshold of age-adjusted incidence. And this threshold was determined as less than 4 invasive cervical cancer per every 100,000 women per year worldwide. So this actually was based on robust modeling done by different groups that had already calibrated models and actually did a parallel exercise to convene into this estimate. Based on this estimate and on the graph that I showed you before, the strategy for the elimination has been based since then in 3 pillars. The first pillar related to the vaccination, by which we want to reach 90% coverage of HPV vaccination of girls by the age of 15, 70% of screening and treatment of women with a high-performance test twice in life, maybe by age 35 and 45 years, and 90% of all women treated adequately and managed adequately, whether they had precancerous lesions or invasive cervical cancer. And this modeling was also based on a model that actually included data from 78 low and middle income countries. If we look at this graph, we could see what would have happened in this sort of pink orange line, that if we hadn't done anything by year 2120, we will have about 1.75 million invasive cervical cancer cases in these countries. While if we apply the elimination strategy, and that means reaching the targets for 2030 of the 3 pillars, by that time, we would have averted 70 million cancer cases. And so that's why we are focusing on reaching these targets. But what do we need to do? So for pillar 1, which is related to the vaccination, we need to secure sufficient and affordable HPV vaccines. We need to improve the quality and increase the coverage of HPV vaccination, improve communication and social mobilization, and innovate to increase the efficiency of the vaccine delivery. I'm very happy to have heard the news about the president of France and what is going to happen in the coming years. I think it's going to be very beneficial for both boys and girls in France. Now, I can show you a map just recently downloaded from the page of the World Health Organization on immunizations. And you could see here that there are a number of countries that have actually introduced the HPV vaccine in their national immunization program as of today. We could see that far away is the Americas, where almost every country has introduced the vaccine. And we have progressed, like in Europe, most countries have done it, in Western Europe, and of course Australia, which was the first country to do it. But most importantly, over the last 5 years, a number of countries in Africa have been able to introduce the vaccine in their immunization programs. However, that doesn't mean that they have started, nor that they have reached the coverage that we are expecting. But overall, there are good news compared to 10 years ago. And if we look actually at the global and regional HPV vaccine coverage as of 2019, this is before the pandemic as well, we could see that we were only reaching 20% coverage in females for 1 dose, and for a complete full doses, maybe 2 or maybe 3, 15%. And again, it was the Americans that was sort of leading this with 70% coverage for 1 dose and 55% for all doses. However, 70% coverage of first dose is still far away from our target of 90% coverage. If we ever look at how the coverage was for boys and girls less than 15 years of age, we know that as 2021, we only had 12% in girls and 4% in boys. And of course, we've seen a decrease within the pandemic because everything had to stop at some point during that period. But no news are really bad. We have extraordinary good news because in April 2022, SAGE actually convened a meeting, evaluated the evidence, and getting to the conclusion that any two-dose schedule for 9 years old and over, boys and girls, lifers, with a minimal interval of 6 months between two doses, was accepted to be implemented. So, and in addition, they say that could happen, or alternative single-dose schedule was as off-label option, because this has not been approved by a regulatory institution, was actually supported for 9 to 20 years old girls and boys. So according to what your president had said as well. So these are extraordinary good news because it opened the space to have more women, in our case, to have access to the vaccine, and more girls that will be protected through life. In Pillar 2, where we are talking about the secondary prevention, screening, and treatment, we need to ensure affordable supply of the test, high-performance screening test, which we are going to call only HPV testing, and treatment devices. We need to try to integrate this process of screening and treatment that is severely complex into primary care or HIV care clinics in the case of women living with HIV. We need to understand the barriers, create the enable environment for this to happen, promote, screen, and treat simple algorithms that will enable the retention and the implementation and the scaling up of the programs, and it will actually support the program efficiency to well use of the limited resources of many countries, and we need to strengthen the laboratory capacity. As well, from 2019, we know that the coverage of ever in lifetime screening in women 30 to 49 years per country was very low. We had 76 countries that have coverage 70% or a bit upper, but we have 126 countries with less coverage. So again, we are far away from our 70%. Nevertheless, in 2021, we released the WHO guidelines for screening and treatment of precancer cervical lesions to prevent cervical cancer. These guidelines are innovative because they included three main points. First, we decided, or we, together with a group of experts, stakeholders, survivors, and representatives from all over the world, we decided that we needed to give the option of having a screen and treat processes that were simple. So we simplified and we recommended to use a screen and treat or a screen triage and treat. Of course, for screening, we were based on HPV DNA testing, and the use of self-sampling was totally encouraged. And also the use of ablative treatment after making sure women are eligible with either cryotherapy or thermal ablation. In fact, we are promoting more thermal ablation now because it's simple, easier to use, and facilitates a lot of things on the clinic. Or of course, whoever needed excision or to be referred should go through that pattern. And so in 2022, we updated the recommendations to include two pieces of evidence that we were not able to evaluate at the time of the original guidelines, which were the use of HPV mRNA on provider collected samples for the general population and for triage on dual stain. For triage, we recommended originally partial genotyping, colposcopy, visual inspection, cytology, and dual stain only on provider samples. Screening should start at age 30, every 5 to 10 years if HPV DNA, or 5 years if HPV mRNA. For women living with HIV, the same applies, except that we didn't have evidence to recommend screen and treat, also because of the large amount of disease that we are going to find. We couldn't recommend HPV mRNA because there was no evidence, no single study to provide us information, and the same with dual stain cytology. And in women living with HIV, we should start screening at age 25 and do it every 3 to 5 years. There are additional recommendations the priority ages, and also that women living with HIV have to be seen more frequently than the general population. We are now going through a very rapid process of evaluation evidence as it comes out, because we know that technology evolves too fast and we need to be efficient to use the resources in the best way. And that's why we are now working on the living guidelines, by which we are going to be evaluating certain topics, technologies, approaches that could actually facilitate the implementation and scaling up of screening and treatment. And so we will do this process as fast as possible. Within 3 years, we should be releasing recommendations as the evidence progresses. Okay, so the first meeting of these living guidelines was held in December last year, and we highlighted 5 topics. The first one is extended genotyping, meaning including about 6 to 8 types that we should consider as under a new algorithm for screening and treatment, the use of cell sampling and different aspects on this, particularly how are we going to apply it and where are we going to apply it, and then also all the evidence related to women living with HIV. And we are considering 2 topics that we need to further develop, which are point-of-care testing and artificial intelligence algorithms. In Pillar 3, what we need to do is to strengthen the affordability and availability, particularly of histological diagnosis and treatment, ensure adoption of guidelines, optimize the workforce to increase coverage, reduce the stigma related to cancer, provide comprehensive care for care survivors, and prioritize palliative care. Cancer pain is experienced by 55% of cancer patients and 66% of those with metastases. We need to ensure collaboration across networks and with UN partners. This is a part of WHO network, and for different things, for the HPV vaccines, for the HPV test, for treatment and palliative care in the case of invasive cancer. We need to actually align with them, because many of these UN partners have offices in different countries and are doing different efforts, like UNICEF is concentrated on HPV vaccination, and we need to work together. And we need to have high-level collaborations, particularly for advocate the global strategy implementation. In conclusion, I want to say that innovations are there. We cannot stop innovating, and offer us an opportunity to accelerate our pathway towards the elimination. We need to have rapid evidence assessment of evolving technology. We need to shift our focus to implementation, to strategic investment and coordinated stakeholder action. And this actually needs to be to start by addressing the gaps that we have in implementation research. We need to have regional action plans that have been developed over the pandemic period. Most of our regions actually have their action plans, but these are an important mechanism for joint action, particularly in implementing, monitoring, and evaluating what we are doing. And we need to support the ministries of health in adopting guidelines, both for vaccination, for screening, and for invasive cancer. And we need to strengthen the links with the community. It's super important to advocate for better counseling, patient education, availability and affordability of all our evidence-based interventions, vaccine, screening, tests, and treatment. And I would like to thank you for letting me speak about this. We can end cervical cancer together.